You know that feeling? Sudden, sharp pain in your eye, the world goes a bit blurry, maybe reddish, and bright light just hurts.
Yeah, that sudden, intense onset.
We've all had maybe minor eye issues, but imagine that really ramped up. That's what we're digging into today, a condition called acute iritis.
Also known as anterior uveitis, yeah.
Exactly. So we're going to break this down, what it is, the causes, the signs, and importantly, the management. Think of this as your high-yield revision guide for acute iritis.
Absolutely. Let's get straight into it.
Okay, so first things first. What exactly are we talking about with acute iritis? Define it for us.
Right. So basically it's inflammation, specifically inflammation of the iris. That's the colored bit of your eye and the bits right near it at the front, the anterior uvea.
Okay, the iris and nearby structures.
Yes, including the ciliary body.
Mm-hmm.
And the key word, as you mentioned, is acute. This isn't something that creeps up slowly. It tends to hit quite suddenly.
How sudden, like over weeks.
No, much faster, usually over hours, maybe a day or two. And it progresses pretty quickly.
Wow, okay. Sudden, fast inflammation at the front of the eye. So what are the absolute giveaway signs? The things that should ring alarm bells?
Well, there's usually a pattern. The big one is a painful red eye.
Yeah.
And I mean, a proper ache, maybe a throbbing pain, not just a bit of surface redness.
Right, the deep pain.
Exactly. Then there's often blurred vision that comes on quite fast, too, and photophobia that's extreme sensitivity to light. Even normal room light can feel uncomfortable, sometimes intensely so.
Okay, pain, redness, blurriness, light sensitivity. Anything else?
Yeah, you might get excessive tearing, like watery eyes.
Yeah.
And visual acuity, how clearly you see, can definitely drop. It's like the eye is really signaling something's wrong.
And eye signaling distress. I like that.
Yeah.
Now, lots of things cause a red eye. How do we know it's iritis and not, say, simple conjunctivitis or something really serious like acute angle closure glaucoma?
That's a really crucial point. The accompanying symptoms help tell them apart. With acute angle closure glaucoma, pain is often incredibly severe. You might see halos around lights, maybe feel nauseous, even vomit.
Very dramatic symptoms.
Yes. And conjunctivitis. That usually feels gritty, itchy, maybe burning. And critically, there's often discharge, that sticky or crusty stuff.
Yeah, the gunk.
Right. Acute iritis typically doesn't have significant discharge. It's more about that internal eye pain, the blur, and the major light sensitivity.
Got it. So pain inside, light sensitivity, no real gunk, think iritis. What actually causes this inflammation to start?
In most cases, the root cause is immune-mediated. Basically, your own immune system gets confused and starts attacking the tissues in the front part of the eye.
An autoimmune reaction.
Precisely. And because of that, acute iritis often pops up alongside other autoimmune conditions. Things like ankylosing spondylitis.
That's the spinal arthritis.
Yes. Also sarcoidosis, which can cause inflammation pretty much anywhere, and reactive arthritis, which can follow certain infections.
Okay, autoimmune links are definitely key. Are there other triggers?
There are, yeah. Infections can sometimes set it off, things like HIV, TB, syphilis, even herpes viruses like cold sores or shingles affecting the eye. Eye trauma can be a cause too. And sometimes, though less commonly, certain medications might be involved.
So infections, injury, maybe meds.
And there's often a genetic component,
Yeah.
particularly a gene called HLA-B27. People with this gene are more susceptible, especially to the types of iritis linked with those autoimmune diseases we mentioned.
HLA-B27. Does having that gene mean you'll get iritis?
No, not at all. It just increases the risk. Many people have HLA-B27 and never develop iritis or related conditions. It's a predisposition, not a guarantee.
Okay. So summing up the risk factors then, it's mainly having those autoimmune conditions, certain infections, maybe past eye trauma.
Exactly. And that genetic predisposition with HLA-B27, it's your underlying health, past events, and your genes kind of converging.
Right. Let's get into the mechanism. What's happening inside the eye during an acute iritis flare-up? The pathophysiology.
So you've got this immune response happening in the iris in the anterior chamber, that fluid-filled space at the very front of the eye.
Behind the cornea.
Yes, between the cornea and the iris. The immune system sends in inflammatory cells, releases proteins. Basically, it creates an inflammatory soup in there.
And that causes the symptoms.
Directly. The inflammation irritates nerve endings, causing that deep ache. It makes the tiny blood vessels in the iris and the white part, the sclera, dilate. That's the redness.
Okay.
And the blurred vision. That can be from the inflammatory cells and proteins literally clouding the fluid, or sometimes the inflammation affects how the iris or lens works.
So the eye's front section gets inflamed and clogged up.
Kinda, yeah. It's interesting, though, because while we know the immune system is doing it, we don't always know the exact trigger that starts that faulty immune attack. Still some unknowns there.
Right. We mentioned glaucoma and conjunctivitis as key things to rule out. What other conditions might look like acute iritis, other differentials?
Definitely need to think about other forms of uveitis. There's posterior uveitis inflammation at the back of the eye. That might present differently, maybe more with floaters or painless vision loss.
Affecting the retina or choroid?
Exactly. Then there's panoveitis, where pretty much the whole uveal tract is inflamed front to back. And intermediate uveitis, mainly affecting the vitreous, the jelly in the middle.
So location matters.
It does. And also things like keratitis, inflammation of the cornea, the clear window at the front. That can cause pain, redness, and light sensitivity too. But the focus is on the cornea itself. A good eye exam is key to pinpointing the issue.
It really is about the whole picture, not just one symptom. How common is acute iritis? Do we know the numbers, say, in the UK?
It's tricky to get exact figures just for acute iritis, but we know uveitis overall affects roughly 1 in 450 people here in the UK.
Okay.
And since anterior uveitis, or uveitis is the most common type by far, it tells us it's certainly not a rare condition. Clinicians see it fairly regularly.
Good to know. So let's really hammer home the clinical features. If someone's trying to remember this for exams or just recognize it, what are the absolute core features?
Okay, let's try a mnemonic. How about PURR?
PUR, like a cat, sort of. Painful red eye. Unilateral, meaning usually just one eye. Reduced vision or blurriness. And another R for reaction to light, that photophobia. PUR. Painful, unilateral, reduced vision, reaction to light. I like it.
Yeah, hopefully memorable. You might also see floaters. And when the doc looks closely, the pupil might be a bit smaller than the other side, or even in a regular shape.
Yeah.
Remember, rapid onset, hours to days, and generally no significant discharge key point versus conjunctivitis.
Excellent. PURR. Okay, someone comes in with those symptoms. What investigations are done to confirm it and maybe find an underlying cause?
Well, the absolute essential is a detailed eye exam, checking vision, the acuity chart, then a slit lamp examination.
That's the microscope thing.
Exactly. It lets the ophthalmologist get a magnified view of the front of the eye. They're looking for specific signs of inflammation cells floating in the anterior chamber fluid, protein flare, which makes the fluid look hazy. They'll also check the intraocular pressure, the eye pressure, to rule out glaucoma. Sometimes they'll need to look at the back of the eye, too.
And what about blood tests or scans? When do they become necessary?
Those usually come in if it's not the first episode, so recurrent iritis, or if it's affecting both eyes, bilateral, or if the history or exam suggests an underlying systemic disease might be driving it.
Like those autoimmune conditions.
Precisely. So blood tests might look for general inflammation markers like ESR or CRP, and specific tests for rheumatological conditions. A chest x-ray could be done if there's suspicion of TB or sarcoidosis.
And the HLA-B27 test?
Yes, HLA-B27 testing is common, especially if ankylosing spondylitis, reactive arthritis, psoriatic arthritis, or inflammatory bowel disease like ulcerative colitis is suspected, as they're strongly associated. These tests help build the bigger picture, especially for long-term management.
Okay, so exam confirms it. Further tests explore the why if needed. How do we actually treat acute iritis? What's the management plan?
Right, the goals are straightforward. Settle the inflammation, relieve the pain and discomfort, and importantly, prevent complications that could affect vision long-term.
And how do we achieve that?
The mainstay is medication, specifically eye drops. Number one is steroid eye drops, something like prednisolone, usually quite frequently at first. These are powerful anti-inflammatories, tackling the root cause and reducing pain.
Steroids first. What else?
Then we use cycloplegic eye drops, drugs like cyclopentolate or atropine. These dilate the pupil.
Why dilate the pupil?
Two main reasons. It relaxes the muscles inside the eye, the ciliary body, which eases pain caused by spasm. And critically, it stops the inflamed iris from sticking to the lens behind it. That sticking is called posterior synechia, a common complication we want to avoid.
Ah, okay. Prevents sticking. Makes sense. Anything else?
Sometimes the inflammation itself or even the steroid drops can cause the pressure inside the eye to go up. If that happens, pressure-lowering eye drops like levodopa or timolol might be added to the mix.
So potentially a combination. Steroids for inflammation, dilators for pain and sticking, maybe pressure drops if needed. How long are we talking treatment-wise?
It takes time for the inflammation to fully settle. You're typically looking at a minimum of 6 weeks of treatment, often longer. The steroid drops are usually tapered down very gradually based on how the eye responds. You can't just stop them
It
abruptly.
needs careful monitoring then.
Absolutely.
Yeah.
Which leads to the non-prescribing side of management. Regular follow-up appointments in the ophthalmology clinic are crucial. They need to check the inflammation is resolving, adjust the drops, and screen for complications like glaucoma or cataracts, which can sometimes be side effects of long-term steroid use.
Right. And what about the patient's role?
Patient education is vital. Understanding you need to take the drops exactly as prescribed, even when feeling better. Knowing it can come back. And practical things like definitely not driving if your vision's blurry or while using those dilating drops, as they mess with your focus and light sensitivity.
Good practical advice. So, assuming people get treatment promptly and stick with it, what's the outlook? The prognosis?
Generally, it's actually pretty good for acute iritis. With timely and appropriate treatment, most episodes resolve completely within several weeks, maybe a couple of months.
And vision.
The majority of people get their normal vision back. The main caveat is the potential for recurrence. Some people, especially those with underlying conditions or HLA-B27, might have repeated episodes over their lifetime.
So, good outcome usually, but keep an eye out for it returning. What if it isn't treated properly or becomes chronic? What are the potential downsides, the complications?
Yeah, that's where things can get serious. We mentioned posterior synecdoche, the iris sticking to the lens. That can distort the pupil and mess with fluid flow, potentially leading
With
to
high pressure.
exactly, leading to glaucoma, which damages the optic nerve and causes irreversible vision loss if not controlled. Chronic inflammation or long-term steroid use can also cause cataracts, clouding of the lens.
So, glaucoma, cataract.
And ultimately, if it's severe, recurrent, or poorly managed, significant and permanent vision loss is a real risk. That's why catching it early and managing it properly is so important. Regular follow-up isn't just about the current flare-up, it's about long-term eye health.
Definitely underscores the need to take that painful light-sensitive red eye seriously.
Absolutely. Don't ignore it. Get it checked out by an eye specialist promptly.
Okay, well, this has been incredibly helpful, a really thorough look at acute iritis. Hopefully for everyone listening, that's clarified things and given you those key takeaways. Remember, PURR, painful eye, unilateral, reduced vision, reaction to light. Think autoimmune links, think topical steroids and cycloplegics for treatment.
Then the importance of follow-up.
Crucial. And if you are revising for the MSRA or just want more high-quality medical education resources, do check out passthemsra.com.
And there's also freesra.com for great free resources too.
Excellent plugs. Thanks again for breaking all that down for us.
My pleasure.